So I want to welcome everybody joining our Prism Eye Rounds today. We're just going to wait for a few more participants to join us. It does take a few minutes sometimes for everyone to join the room. So we'll just wait for a few minutes and we'll get started very shortly. All right, well, thank you. I want to welcome everybody. We still have participants who are coming in, but I want to welcome and get our program started. We already see a lot of stuff happening on the chat box. And by the way, for the panelists that are responding, if you want to reply so everybody can hear, then when you actually type your answer, click on everyone as well in the meeting. That way, anything you have that comes in will be sent out to everybody as well. So thank you, everybody, for being here. We have almost 500 people on already, and we'll get started. We've got a great lineup here. I can tell you it's going to be a very interesting rounds today with 3 interesting, great cases. Just a bit of housekeeping before I hand it over to Jeb, who's been helping run these rounds. You will be able to ask questions in the Q&A box if you wish. Some of you are writing stuff in the chat box. I see the chat's already kind of going crazy. And so you're welcome to do it there, but it is certainly easy for you to write stuff in the Q&A box as well. It'll be difficult to get to you if you raise your hand, although if there's somebody that we can get to, we'll try to get to. But we do have a great group of panelists that are part of this group that I think you'll find to be very, very helpful, and I think will add a lot of good value. We do, of course, run these rounds every Wednesday at 3 o'clock Toronto time and every Saturday at 12 noon. So stay tuned for that. We have a special rounds as well next Tuesday with Ophthalmo University. That's geared toward those surgeons that are still in their learning curve and working on getting to perfection. It goes without saying, these are unprecedented times and times of uncertainty, difficult times. Many of you, all of us have been touched by the pandemic, whether it's our personal or practice lives, our friendships and difficulty in seeing each other are all challenges we face. And my first message to everybody here on behalf of the presenters and panelists is to wish you good health and safety and security. Take protection, stay at home, and use personal protective equipment if you need to when you're seeing patients and seeing people. We will overcome this, and if anything, this has brought us together in ways that we never could think of. And certainly Zoom and other webinars have given us the format to do that. So I wish you peace and love and greetings and security from here in Toronto. We're going to start off, and I'm going to hand it over to Jeb, maybe to get the ball rolling. So thank you, Jeb.
Perfect. So we've updated our logo, as some of you can tell, and also we've actually we now have a dedicated email account for any types of questions or case or anything that you want to present. Please send your comments, questions to ike.webinars@prismi.ca. And as previously shown, this is just to quickly show what type of presentation formats we're looking for. So either you want to do a lecture, a case presentation, or an article that you want to review. Don't worry, we'll be sending this to you if you do want to present something. So, this is just kind of to give you a brief idea of what we're looking for. Again, it's the same email address in case you have questions. Now, in terms of our speakers today, we're starting off with Dr. Gisela Santaella. She's currently a cornea and refractive surgery fellow at the University of Toronto. She did her previous ophthalmology residency in Colombia, and she's also done a previous cornea and refractive surgery fellowship back in Colombia as well. And on her panel, she has Dr. Alan Slonovic, who's a professor at the University of Toronto in ophthalmology. He's also vice chair of education, continuing education, and director for ophthalmology at the University of Toronto. And he's clinical director of the fellowship or the service at the Toronto Western Hospital. Last but not least, we have Tanya Trin, who's also currently doing her fellowship in cornea and refractive surgery at the University of Toronto. She's also the chief fellow, did her previous training in Australia. And for our second topic, I don't think this man really needs any introduction, but he's otherwise known as the Wizard. He'll be the speaker for the second topic. On his panel, he's going to have Dr. Arsham Shibani. He's an assistant professor of ophthalmology and visual sciences at Washington University in St. Louis, Missouri. We also have Dr. Javo Campos, who's a glaucoma and anterior segment surgeon at Memorial Regional Hospital, that's in Newfoundland. And for the last speaker here, we have Dr. Natalia Maez, and she's currently doing her glaucoma fellowship at Queen Victoria Hospital. This is in UK. She did her previous training in Vancouver, BC, and before that, her residency in Brazil. On her panel, we have Dr. Gok Ratnarajan, who is currently a consultant glaucoma and anterior segment surgeon at Queen Victoria Hospital in the UK as well. He's the director of the glaucoma fellowship there. And we have Dr. Joshua Teichman, who does cornea, complex anterior segment, and refractive surgery at Prism Eye Institute, Trillium Health Partners, TLC, and University of Toronto. And that is that. So we'll get you started, Gisela.
Thank you, Jeb. I'm just going to just actually start with a little poll. If you can go back to our cover slide, Jeb.
Yeah, perfect.
Just to get everybody in the mood to use polling, I'm going to just launch this poll. Hopefully you have it in front of you here. And the question we're asking is, where are you viewing this from? Where do you live? It's pretty obvious. The choices: North America, Latin, South America. Sorry, I had to combine you guys. Europe, Middle East, Asia, and Australia, New Zealand. So we have about just under 600 of you here online today. So we have a lot of people here online. It's great to see everybody. And so please log in. Looks like we have some representation from a lot of the world here. Some of the world is sleeping today, of course. We have Durham, North Carolina. My man, Alan Carlson, just logged in. We're quite privileged to have you here, Alan. Thank you for being with us. I'm sure Alan Slonovic knows Alan Carlson as well. Two big corny people named Alan. Bad joke. And maybe we'll get Alan to speak up on some of these things that are coming up today for our cases. Okay, so let me just end the poll here, and I will share the results for you to see them. Looks like we've got looks like the South Americans beat out the North Americans today. Pretty big split. They're probably here for you, Natalia and Gisela. And we have some from Europe and the Middle East, and no one from Africa. We got to work on Africa a little bit. Okay, so that's basically the group we have with us here. I'm going to now ask Jeb to maybe stop sharing, and we're going to get Gisela to start. And thank you, Gisela, for being here and presenting today with us.
Good morning, everyone, and thank you for having me. So it's going to start sharing.
Yeah, perfect.
I'll do our case, get right into it. So again, thank you very much for having me. I think that these initiatives are helping us all stay not only safe, but sane at the same time. And so I really encourage everyone to continue following them. And I'm just gonna go straight into our case. So we have a 31-year-old male that was referred to our cornea clinic with a complaint of 4 months of worsening of vision in his left eye. He was sent for a corneal assessment. He had history of LASIK surgery in both of his eyes in 2009 and the implantation of a cosmetic iris implant in 2012 in both of his eyes. He was HIV positive, although his viral load was non-detectable, and he was treated for that. He currently didn't have any issues. And he was being treated with FML 3 times a day and Combigan twice a day because of some swelling and some high pressure in that eye. That's what he told us. And this is what we found at the time of the examination. So you can see the big difference between his right and his left eye. So his right, let's start with his right eye. Very, very quiet eye. you can see the cornea is pretty clear. If you look with attention here, you can actually delineate the LASIK flap that he had preferred to have done previously. Inside in the anterior chamber, you're finding the cosmetic iris implant. And if you are able to see here in the superior margin of the pupil, you can also see like the actual iris and some pigment dispersion in the anterior capsule of the crystalline lens. On the contrary, in his left eye, you can see how injected the eye was. The cornea was quite swollen. You can also delineate the flap right here, and you can see some signs of microcystic edema here. And it's actually really hard to see the structures in the anterior segment because of the corneal edema. So in this table, I wanted to just compare what we had for both eyes. So his right eye was not too compromised. His vision was correctable to 20/30. His pressure was 24. As we described, his cornea was clear and there was a presence of a LASIK flap. Of course, we're finding the implant inside his eye. The back of his eye was normal at that point, but we do find a low count in his endothelial cell density, and the pachymetry was 535. When you compare that to the left eye, you can see how compromised this eye is. His corrected vision is 2300, the pressure is 20. Besides having a LASIK flap in the cornea, you can find the severe amount of edema that eye had. And the back of the eye was we were not able to see it because of the edema in the cornea. The endothelial cell count in this eye was undetectable. The machine was not able to detect cells in his endothelium, and his corneal thickness was enlarged. So this is like the first impression we get, but when we do like a more judicious examination, we find that there's something else going on. So just for those that have never seen IFS or interface fluid syndrome, this is an accumulation of fluid under the LASIK flap. And for you to be able to see it, first of all, you have to think about it and look for it, because otherwise you're not going to find it so easily. You need a very intense light, thin beam, and of course, the light should be tangential to the cornea. And here you can see the fluid accumulating under the LASIK flap. Just for like documentation, we ordered an anterior segment OCT, and you can see how there was this fluid accumulating under the LASIK flap. So when we're talking about cosmetic iris implants, there's been many publications that have explained and have illustrated very nicely what happens to these eyes because of the implants. And I just wanna make a little brief summary of what's going on. So there are multiple structures in the eyes that are going to be affected by this device. Of course, the iris is the first one. There's gonna be trauma to the iris, dispersion of pigments and changes to the pupil. This can also generate the formation of PAS peripherally and lesion to the trabecular meshwork. Both of these will most likely increase the pressure in the eye. There can also be formation of cataract induced by the steroids that are normally used to treat this inflammation that's caused because of the iris chafing. And of course, what was like more evident in our patient, that's the lesion to the endothelium and corneal decompensation secondary to this. So I just wanted to remind everyone that these devices are blinding. If we don't do something, this patient is not going to do well. So even though patients tend to be very emotionally attached to these cosmetic implants because they give them like a sense of identity, and of course there is a reason for them to have the desire to change the color of their eyes, right? So sometimes they don't really want to get them removed, but I think it's important that to everyone that's watching that they know that this is a very dangerous thing and we really have to act on it. So up to now, we have a patient with corneal edema, the presence of cosmetic iris implants, a past history of LASIK. The status of the lens, we're not sure because the edema doesn't let us evaluate very well, and apparently some pressure issues. So I just wanted to ask the panel, what would you do up to this point? I don't know if maybe Dr. Slomovic or someone else wants to tell us what their approach would be.
So I think just thank you, Giselle. That was beautifully presented. You and I did something on CTV a while ago, and that was for the new color implants. I think there are two different types of implants, iris implants. One is a therapeutic implant, like the Morcher implant, which we all use. The other one it started with the new color iris implant, and this is the bright color iris implant, and this is a new generation. Neither are approved for use in North America, and therefore these patients end up traveling far away, spending a lot of money, and that's another reason they don't want them removed. They are dangerous to the eye. They will cause uveitis, they will cause glaucoma, and they will cause corneal decompensation. I believe we published this case as the first bilateral corneal transplant as a result of these iris implants. Now, the bright iris implants, I won't occupy too much time, but the reason they're a little different and they're a newer generation is because they're customizable. They come in a couple of different sizes. They also have fewer fixation devices in the angle, and the underneath of these lenses have ridges that have been drilled into them, so that supposedly it allows for flow of aqueous between the iris and the lens and the implant, and less ischemic damage to the iris. But really, in reality, this does not hold place, and these eyes end up resulting in severe ocular complications requiring, in many cases, surgery.
I think it's Gisela makes a really good point, is that although these patients are quite emotionally invested in these cosmetic implants, they do need to be counseled that even despite, in this case, I mean, your main question here, Dr. Santaella, is what do we do in this case? And we have a known cosmetic and unnecessary foreign body in the anterior chamber that's causing a whole host of issues to the cornea, ongoing inflammation, pressure issues. And it's difficult in this case with the interface fluid syndrome to really know what is going on with the pressure here. And we don't have a view of the back of the lens, and we have no way of tracking the progress of this patient. And so I think the first thing that needs to happen is that this needs to come out, but it's really important for patients to know that this is not the end of the story, and they do require ongoing follow-up, some of these patients for life. And this is not going, I think in this patient, he's already had the LASIK to correct his vision. Then he's already, again, had the iris implant. Now we're going to have to move to taking them out. And potentially he's setting himself up for a number of other ocular procedures. So I think counseling is really important, and having multidisciplinary input involved early on, and making sure the patient understands the importance of follow-up is really crucial here.
One more point. I think imaging is so important, because we saw the gap between the flap and the stroma. It's a little bit harder to see, but if you can do an OCT, you really can see that you make the diagnosis. And we actually published that in an earlier situation of interface fluid syndrome. So imaging is important, and OCT is very important. And one last point is that usually you get interface fluid syndrome after LASIK when there's a real spike in pressure that's often camouflaged by the fluid interface. So here you have a different set of dynamics, physiological dynamics, where the fluid is accumulating because fluid is allowed to come in from the aqueous because of the damaged endothelial cells. So that's just something to keep in mind.
Yes, we're going to go into that in a little bit more, like as we go further. So I just want to continue with what we did. So basically the idea was to discuss if you guys would go for a removal of the implant that we know is completely necessary, but if we would combine that or not with an endothelial transplant. So in our case, we decided to only remove the implant and give the eye some time, because as you can see, the eye is very injected. There's a lot of inflammation going on. So I'm just gonna roll the video. It's a very short video. I just wanted to point out that we have previously done 2 paracenteses and a 4mm corneal tunnel here. After that, we have separated with viscoelastic the device from the patient's iris. And then you're gonna see how we go inside the anterior chamber with a MST scissor, creating 2 radial cuts, protecting the endothelial with a spatula, as you can see there. And then we're removing the implant that folds on itself, and it easily comes out through this corneal tunnel that we had previously done. And then this is the implant once it's outside of the eye. So as Dr. Zlomovic was pointing out, this is the 2nd generation that's supposed to create less harm, but you'll see that this is not the case really, but these are the little triangular supports that are supposed to create less damage to the trabecular meshwork, and the grooves that are at the back of the implant that are supposed to allow for a better flow of aqueous between the iris and the implant. So this is the patient 1 week after we removed the implant. And as you can see, there is a lot of iris atrophy. The pupil's very, very large. The cornea is still very swollen, and we gave him a full month, but the cornea was not improving and the cornea was still very, very swollen. So I was gonna call here Dr. Trin to see what would her approach be with this decompensated cornea that's not improving.
So I think we've done the right thing by removing the offending agent. And it's always a question of how much you do it, knowing that the patient is probably going to be set up for multiple procedures. But it's been a month down the track. And I think that if we haven't seen anything in terms of improved clarity, or the pachymetry is not resolving and it's already been a month, then we do need to seriously think about some form of endothelial keratoplasty. And then the question becomes what type of procedure, whether you're looking at a DMEK or a DSEK. And I think in these cases, just thinking ahead and knowing that these eyes can be quite complicated going forward, is that in this case, a DSEK as soon as possible would be my first choice. Because we know that potentially that, we're going to need to repeat procedures, or we're going to need to have glaucoma drainage devices as a potential, or other glaucoma surgeries. And I think that a no fuss procedure with something that we can get in and out quickly, and just to help us attain some clarity and control over the situation before the cornea goes too far.
Thank you. Thank you. Yeah, so exactly that's what we did. We decided to go for a DSEK because of the distortion in the pupil. We were not able to get the pupil to close fully, like in what you ideally want in DMEK. So we decided to go with a DSEK. I'm gonna roll the video, it's very short as well. First of all, just to highlight that we have removed the epithelium to improve visualization, and now we're gonna proceed with descematogrexis. We actually had to use this 90-degree scraper because this descemes was very, very attached to the corneal stroma. We were able to remove it. And then you're gonna see the pull-through technique with the DSEK graft coming into the anterior chamber. We have an AC maintainer here. And then once we've centered it, we were able to get the graft centered and a good size of an air bubble to attach it to the corneal stroma. So at this point, we have removed the cosmetic implants, and now we think that, of course, things should start getting better because we have done the corneal transplant, and this should get rid of the corneal edema, improving the endothelial function of the patient. But to our surprise, this is what the patient looked like 2 weeks after the DSEK surgery was done. So he came in as an emergency. He had a lot of pain, photophobia, tearing, of course, and foreign body sensation that was very, very symptomatic. So as you can see, the eye was still very injected, and we had this irregular epithelium image that we were not really clear what it was initially. When you do the slit evaluation, you see that the amount of fluid under the flap has enlarged severely. There's a lot more fluid than in the initial evaluation of the patient. And when we did the OCT, well, you can see at least in my case, this is the largest IFS that I have ever seen, the largest amount of fluid that I have found under a LASIK flap. We were actually debating, is this IFS? Is this a gigantic bulle? Or, because it was so evident. But yeah, they finally agreed that there was an enlargement of the interface fluid syndrome that was accumulating and that we had noticed since the initial evaluation. So the question here would be, what's making this worse? Like, we are removing the iris implant, we are improving the endothelial quality. As you can see here, the DSEK graft is fully attached and there is no problem with the surgery itself. So I don't know if anyone has any idea why the amount of fluid under the flap is actually getting worse instead of getting better.
I'm gonna jump in for a second as a panelist on one of the later cases. But I would argue on that anterior segment OCT, that's a bulle. Because you can still see, I know I can't share my screen right now, but if you look, you can see a delineation about 100 microns deep after the bulle. So I think that's a bulle. I think you can see a flap connected still to the stroma.
Josh, if you compare that, I agree with you. That's a very thin flap. But if you compare that with the earlier OCT, you'll see that there was an area of a little bit increased cornea, like you see over here, where it definitely was a flap.
Agree completely before, for sure.
That it actually, like, it just goes to the edge of the flap. It doesn't go further than that. So that, you know, well, it's debatable, but another thing that we found, and the point I wanted to make, is that there was a big difference between the pressure in the center, of course, over the flap, and the pressure measured peripherally. So when we measured the pressure outside of the flap, it was 30, and centrally it was 10. And we attributed this to a steroid response, because every time we do a corneal transplant, we start the patient on steroids. And of course, here we did the same. So he was receiving Tobradex 4 times a day. And we suspect that this change in treatment and this increase in the steroid triggered a spike in pressure, and that this also made the IFS worse.
I'm just going to jump in for a second, because we have some really great people online here. I actually brought in Alan Carlson. I don't know, Alan, if you're on the line here, but Alan, I know you've described this many years ago in the 90s. Any thoughts on this picture here?
Is my audio on right now?
We got you, Alan. Thank you. From Durham. Thank you.
The first case I saw was as a third opinion back in 1997, when it had not been described yet in the literature. In fact, when I recognized this fluid in the interface, I did a tactile tension out in the sclera, and I could tell the pressure was in the 50s. And it obviously read much lower on the cornea. So I was actually calling this at that time pseudo low tension glaucoma, because it really was elevated pressure secondarily, but it would give you a false reading when you get your measurements on the cornea. So that needs to be a fairly important part of what you do. Even if you think your pressure is low, you want to get that pressure lower. And lately on cases I've seen, I've added the the Dave Epstein drop, the
rock inhibitor. Rock inhibitor.
Yeah, rock inhibitor.
Repressa, yeah.
Yeah, it's a Repressa. So I've been adding that, and we've had some interesting results with that. We get this peripheral bubbling in the cornea, but we've had some surprising improvements centrally. In this particular case, I do think that's a bullseye. And I was wondering if you did venting incisions initially, because when you did your DSEK, adding the venting incisions would give you not only the added benefit of venting the interface between the donor tissue and the stroma, probably Duaw's layer, but also you get the benefit of decompressing the LASIK interface. Okay.
We started doing that many years ago with when we started doing DSEK, but when the reports started coming out, you were getting epithelial ingrowth into some of them. There were some infections at the interface, so we basically stopped doing that. I think the important point, Alan, you make there is this, whether you're seeing this in the context of lamellar keratoplasty, whether you're seeing this in the context of a cosmetic laser procedure, the important thing is, and eyes have gone blind because of this, is you get a false low reading with what could look like DLK, and the treatment for DLK is either more steroids or lifting the flap and washing it. The problem with more steroids here is, this is a steroid response resulting in a fluid accumulation where there's a potential cavity. So you could get very low pressure centrally where the bullae or the interface fluid acts as a sort of shock absorber. The important point to remember here is, just because the central pressure is low, don't go with the feeling of confidence that you can add more steroids. Think about a steroid response. We did tonopine pressures at the periphery, and lo and behold, it was significantly elevated and responded very well. Both interface fluid and bullae would both respond favorably to a reduction in fluid. It's hard, as Gisela was alluding to, when with boots on the ground, you can actually see where the bullae or where the interface fluid comes from, and it just went to the graft or the flap interface, and that was the area of involvement. So I think the important point is to remember, check the, don't have a false sense of security if you have a low central reading. As you did, Alan, you checked with finger pressure, but now we have a tonal pen. You can even check the peripheral cornea, and that'll give you some good readings.
I remember the first case I saw, they were on their 12th bottle of steroids, and the referral diagnosis was that they were having an idiosyncratic reaction to steroids. So the doctors were making up steroids that didn't have a preservative. They thought it was a reaction to a preservative. By stopping the steroid and putting them on pressure lowering drops, the patient came in the next day with uncorrected 20/40 vision down from 2200.
And I think Gisela's going to show you what how we manage that and how your words are so true.
Great.
Okay, so I wanted to talk a little bit about PISC or IFS, whatever you like to call it, but I think we've already touched base on that, and I don't want to extend the case too much. It's just to say that it has been reported previously, and endothelial keratoplasty, both DMEK and DSEK, have been reported to treat these accumulation of fluid under the LASIK flap. So what did we do? Basically, we had to taper the steroids. We went from dexamethasone to FML, and we added tacrolimus because, remember, we just did a corneal transplant, so we don't want to leave or increase the risk of our rejection in this eye. And of course, we needed glaucoma therapy and try to reduce the pressure as much as possible. It wasn't easy, it took us about a month, but we finally got rid of the fluid under the flap, and the eye improved a lot. The injection improved a lot. The clearing of the cornea also improved, although we were left with a little bit of haze over the area where the fluid was accumulating more. But the patient had controlled pressure and didn't need any other procedures done, and his vision was correctable to 20/40. I just wanted to touch base on this interesting paper I found when I was going over this case. And it's from Dr. Schlenker's group, and it's a case of cosmetic implants. In the one, there was high pressure only, the cornea was okay. And after they removed the implant, they also did goniosynechialysis. So I would like to open the conversation for the glaucoma experts, see if they consider that doing goniosynechialysis at the time of explantation is something that we should be considering routinely for the cases, or I don't know, what are your thoughts on that?
Well, we have actually Dr. Schlenker online. I just brought him online as a panelist. So Matt, what are your thoughts on this, and also maybe for the fellow eye too?
Thank you, Gisela, for bringing this up. I think it's worthy of discussion. In terms of your question for goniosynechialysis, I think there's two components to it. I don't know if Kashif is here as one of the participants, but he said something that was striking to me when he took out some of these cosmetic implants. He said the first thing one of his patients went for was a small mirror to look at what her eyes look like. So of course, keep in mind that these patients are quite concerned about their iris appearance. And the first thing that struck us when we were taking out these cosmetic implants was with how distorted the pupil was. So the goniosynechialysis, if nothing else, can be done to hopefully restore some of the anatomy as much as possible. Now you have to be a little bit careful because there can be some associated atrophy and pigment release at the same time. So I think the first step is some very gentle tugging of the iris to reshape. You can consider using a focal cautery as well. And in an extreme circumstance, you may want to even consider doing some suturing as well. Now, the second component, which is a little more relevant for the glaucoma, is trying to open up the angle as much as possible. In this case that you have up here, she had significant synechial closure, unfortunately. And I have to say that the goniosynechialysis from this respect was not very efficacious, in the sense that every time we pulled on the iris, there was a significant amount of bleeding. So these are not your acute angle closure peripheral anterior synechiae, but much more fibrotic process in some cases. So unfortunately for this one, we weren't able to open up a lot of the angle, but we have been able to open up enough of the angle that her eye pressure has been reasonably controlled. Gisela, if you don't mind, I can also comment on this this patient you're presenting, because I think I happen to know this patient as well.
Yes.
This patient was a high myope, so should have quite open angles, and I saw on the chats as well. Unfortunately, he has some peripheral anterior synechiae as well, secondary to his iris implants. So I think the management from a glaucoma perspective on these patients is quite difficult. I don't know, Giselle, are you getting to that, or should I delay commenting on that?
No, go ahead. I was going to ask you, actually, my next slide is just what are we going to do for the second eye? That is also the question that why we had you see him as well, because we're debating if his pressure is going to be an issue as well for the second eye.
Yeah, so I think when you guys sent him to me, you had him on Diamox, which I think is actually a good idea for him. He's young, he's healthy. He's also of note, for those of us thinking about filtering surgery, a little bit darkly pigmented. When you sent him to me, his second eye had very painful bullae, and they were small bullae, not like the ones that you just showed, which made it actually very hard to examine. And unfortunately, the gonio was quite difficult as well. But it did show, despite his previous high myopia, a significant amount of peripheral anterior synechiae. So I think the options for these patients is, one, to just try to control the eye pressure as well as possible as you're doing your explantation and endothelial surgery. The other possibility would be do concomitant glaucoma surgery. The one that strikes me would be to do a trabecular bypass approach, because he's young, he's steroid responder, and you may be able to open up his angles first with some Goniosynechialysis. I know Alan and I had spoken about this a bit. One of my concerns, so for instance, one of my approaches would be a gap procedure in this eye, is that if we get heme, which does happen while doing our gap procedures, and you're doing, say, a DMEK or a DSEK, that we could get some heme caught in between the interface, which I think would be quite devastating from a visual perspective. So I'm not sure that it's good to do as a combined, but it could be done soon after if needed. And of course, the other option would be a filtering surgery approach. And the problem with a filtering surgery approach from a combined perspective is the importance of having that bubble to adhere your endothelial graft. And I worry that, at least with our conventional approaches, such as a trabeculectomy or a large bore tube shunt, that some of the air would be released. This could be dealt with potentially by tying off or not putting the tube in, but then you have the pressure up, which could be leading to these interface syndromes that you're talking about.
Yes, thank you. Yeah, so I think that is interesting, the fact that we have all these different perspectives. What are we going to do for the endothelium? What are we going to do for the angle? And well, this is just basically the case I wanted to bring to you, and thank you for having me here. Just some take-home messages. So just for anyone that hasn't seen it, if you have a patient with a cosmetic iris implant, remember to look for glaucoma, evaluate the angle, be aware of the risk of corneal decompensation, the presence of uveitis, and the formation of cataracts. And for the IFS component, always remember, as we've spoke about, the differences in IOP measurements centrally and peripherally, and the risk when we use steroids of having a pressure spike and worsening of this syndrome. And also to remember that the interface fluid is not only accumulated by high pressures, but also by endothelial failure. And then we have to address all of these things in a very complex scenario. Thank you.
Gisela, great job. Matt, two questions about doing the synechialysis. Number one, does length of time that the implant has been there, does that color your judgment, number one? And number two, is an inflamed eye another factor you would take into consideration? Never mind the fact that we couldn't see well, but just moving forward, with those factors in an eye that's had long-standing PAS, what's been your success rate?
Yeah, I completely agree with you that the longer the process has been going on, the less chance that goniosynechialysis is going to be effective. And it may be technically more challenging, again, leading to bleeding, secondary fibrosis. And also, when we remove, there's probably some pigment that's left over and the trabecular meshwork is permanently damaged. And that's why from a glaucoma perspective, I would still consider a trabecular bypass approach for those patients with the chronic PAS. Your second one, I think, is also valid. I think the more inflammation there is, the higher chance that there'll be PAS formation, and the more fibrotic that PAS will become over time. So I think those are considerations. The sooner you can get these out, I think the better chance of reducing the risk of all the different manifestations of this.
I just want to just get maybe Arsham, we had a couple of comments, and there's been some questions, by the way, from the chat group here about, what's the best way to measure pressure in these situations? Eye care home, I think Ian Connor mentioned about eye care. Someone asked about a Perkins, could that be used? And then the other questions around, well, should this be managed from IOP perspective first before doing a corneal procedure? Those are some questions came up. Arsham, do you want to add your thoughts on that?
Well, let me just talk about the ROCK inhibitor with the corneas. There's published reports. We just published a case series of 3 compromised corneas after starting ROCK inhibitors can rarely cause like a pretty impressive honeycombing. So the looks like more stromal layer and subepithelial layer almost look like a honeycomb truly. So I know we were talking about maybe adding these with like post DSEK patients or even pre-op, but if you do see that in those cases, you really need to consider stopping that ROCK inhibitor.
Okay, well, thank you. I think we're gonna move along here. That was great chat. Thank you for all the panelists. Thank you for Ellen and Matt for joining in as well. And I'm going to then lead into our next presentation, which is moves into a bit more on the glaucoma angle, literally. And again, we have our panelists who I think will be joining us as well. So my talk is about small. These are my disclosures that are here, relevant or not. And I just want to say again that, I mean, for all of us, not being in the OR means not being with our team. And these are difficult times because we're so used to being with our team. And when we're not with our team, we realize how valuable that team is. And I want to recognize my fellows. And I know they, all year, they've been wishing they didn't have to see me. And I think maybe now, I hope they want to see me more often. So just want to recognize that as well. I'm going to present this case here, and there's some polling questions that'll come up hopefully shortly as well, if I can get my cursor working. This is a 33-year-old male nano-ophthalmic patient that was referred to me, actually referred from the US, who's a plus 15 diopter patient. His best corrected vision is as listed. Not too bad, but amblyopic in the left eye. And his pressures on presentation for the last month or so were between 30 to 50. When we looked at the angle, there was what looked like 360 degrees of PAS formation. I've just put a specular microscopy up here because I know we have a lot of cornea people here, just so you can see that as well. So certainly for a young 33-year-old, it is down as well. This is just a picture of both eyes. You can see the right eye is significantly more shallow than the left eye, although the axial length actually was pretty similar between eyes. The right eye was 16.44 and the left eye was about 16.1. The AC depth in the right eye, you can see I particularly highlighted here, was 1.4 on the optical biometry. And the lens thickness, for those of you that are probably wondering, was 4.73 millimeters. It's difficult for him to do a visual field considering his presentation, but the nerve did not look terribly damaged. And I will say that, didn't look terribly damaged. You know, his RNFL was a little lower in the right eye than the left eye, but we weren't very impressed with his presentation here. So I'm just going to just go to our panel, our poll for a second here. And actually, maybe I'll stop and ask our panelists about what would they want to do, or was there any more information they'd like to have in terms of this case? So I think we have Havo and Arsham to first start off with discussion on this case.
You know, these are in some ways the decision's kind of made for you when you can show that you have a shallowing of the AC, as long as there's not a posterior mechanism causing the issue. One of the things you need to rule out is there a large choroidal effusion? Do they have trauma? Is there a tumor behind there? Do you have weak zonules, maybe post-trauma, like I just mentioned, that are causing the issue? But if you can pin it down to where this really is an axial length issue, which in this case really is, it's decompressing the anterior segment, and then I'm sure we'll kind of get into some of the nuances of that. But You probably don't have the time to get something, at least in the US, that can refractively get him back to close to plano if that's what he chooses. But it's really going to be leaning toward lensectomy here.
Havo, what do you think is going on in this case?
Yeah, I totally agree with you, Arsham. So can you guys hear me, by the way?
Yep.
Great, perfect. So we have a patient, a young patient with Nano-ophthalmos and angle closure. And I really would like to know, like Arsham mentioned, is this purely Nano-ophthalmos and a carotid anterior segment, or is there something else, especially due to the asymmetry? So if you could get a UBM, that would be very useful. You also want to rule out low-lying choroidals or effusions. And it's also useful to assess the scleral wall thickness, right? These patients tend to have very thick scleras, and that might dictate your approach in the OR, where you might want to be doing prophylactic scleral windows as well.
I think you touched a lot of good points here. And as you said, I think these patients, you really do require a B scan. I would be very hesitant in not doing a B scan or some sort of posterior segment imaging, because sometimes you find effusions, sometimes you find anterior annular effusions, and certainly looking at the retinal choroidal scleral thickness, which I'll talk about shortly, can be indicative of complications. So I think it is helpful to have that. This particular patient, you can see, didn't really have any frank effusions, but had a very thick choroid, which we'll explain shortly. So this is the presentation here. I'm going to ask the attendees here to take a poll. You can answer the poll questions here. Can everyone see the poll questions? Are they up there? Yes?
Yes.
Jeb, can you see them? Okay, so start voting. No one's voting yet. Okay, that's good. So your treatment here in this case would be a trabeculectomy or some sort of bleb subcons mixed procedure, a tube shunt, phaco alone, phaco with goniosynechialysis, phaco with goniosynechialysis, and iridozonular hyalodovitrectomy. Sorry for the big words here. Phaco with goniosynechialysis, iridozonular hyalodovitrectomy, and sclerotomies. Or would you also think this patient requires a pars plana, at least vitrectomy or some approach? So please go ahead and vote. I'm going to again ask Arsham and Havo and to start off again with what you would do for this case.
So a couple of things here. I mean, if you're looking at axial length, the results just popped up.
Yeah.
Let's see. If you're looking at axial length,
don't cheat. Don't cheat, man.
Who, me? Yeah, I know. I got to go off the audience, man. If it's less than, in my mind, less than 20, that's when you really start looking at adjuvant procedures. It's a pretty complicated topic to talk about, but I can try to simplify it this way. If you have effusions that are already present and you go in, that in my mind is a lock for you should do scleral windows. Yeah. If your axial length is less than 19, we have a randomized study that showed us that scleral windows prophylactically in cataract surgery reduce the incidence of postoperative choroidal effusions. That was the only thing that popped out positive. With axial lengths really under 20, your risk of postoperative malignant glaucoma is about 15-fold higher than what it would be in axial lengths between 20 and 21. So once you get below 20, the IZHV is pretty critical. Now, as far as doing a pars plana vitrectomy, kind of depends on, can you make room to do the phaco or not? How comfortable are you? The pars sometimes doesn't exist. You have retina running all the way up to the limbus, it seems like sometimes. So that's where it's going to be more kind of surgeon call. But those are kind of my 2 cents there.
Okay, I think you covered it very well. Did you want to add anything to that, Havo?
Yeah, pretty much said everything, Arsham, but I would like to add that in these cases, it's extremely important that no matter what happens during your surgery, you don't allow the anterior chamber to shallow even more, because that can make things a lot worse.
You can see by the polling that it looks like there was a smattering of cases of options here. Some of you did opt to, well, most of you opted to do phaco of some form. Looks like a number were suggesting a pars plana vitrectomy or a TAP along with this as well, and some adjunctive procedure with this case as well. Okay,
I would also just like to add one more thing quickly.
Yes.
Given the asymmetry, it would also be important to be prepared for some kind of zonular weakness or laxity. There might be a component of weak zonules here as well, right? So yeah, you might want to be prepared.
Yeah, I want to just go back to this here because it is so no one really answered what's the diagnosis here, right? This is nano-ophthalmos, but nano-ophthalmos is not a diagnosis. It's an anatomical description of an eye. These nano-ophthalmic eyes are at risk for certain problems, but yes, this patient actually presented, based on what we saw here, you see that the B-scan, this patient actually presents with malignant glaucoma. And yes, malignant glaucoma usually is something we see post-filtering surgery and sometimes after post-phaco, but can happen spontaneously as well, and has been reported after laser procedures and even spontaneously. So lens thickness was normal, no phacodenesis, no choroidal mass, nothing else, no effusion in a small eye. You got to think about what's going on here. You can see the asymmetry between the eyes quite evident, right? I mean, this left eye, actually, the angles are open and pretty good. So that's the diagnosis. So we do have to manage the malignant glaucoma scenario. Some people call it aqueous misdirection erroneously, but we need to address that. And of course, this patient's pressure is very high. I think others have commented about, is this the lens dislocation? Those are all good comments, but this patient didn't really have an issue. Now, let's just talk about how small is small, and Arsham kind of alluded to this as well. You know, the average eye is about 23.5. Once you start getting down to 20 millimeters or lower, that's where most define nano-ophthalmos, although there is some variability in what's described there. And nano-ophthalmic eyes are fraught with potential risk. We know some of these things, of course, just from personal experience. Of course, they have steep corneas, irregular astigmatism, angle closure glaucoma can present, as you saw here, macular folds is important. These patients are at risk for CME as well. So even though you may do cataract surgery and resolve their pressure, these patients can go on to develop chronic macular issues. And that's important for patients to know that, even though you resolve their IOP issues. They can get uveal effusions, malignant glaucoma, which are the two serious issues, as well as serous retinal detachments as well. It is helpful to do a B-scan, as I said before, to assess the level of choroidal expansion or effusion. Make sure you differentiate the two. An effusion, of course, is frank collection of fluid under the choroid, as opposed to simply the choroid thickening. And it's the choroid thickening which basically is associated with malignant glaucoma, and is probably the common factor or the common element in triggering a response to shallowing of the chamber. Some studies have shown that if you can measure the retinal choroidal scleral thickness of greater than 2.5 millimeters, these patients are substantial risk for developing intraoperative and postoperative complications. So it's sometimes helpful to measure this as well. And indeed, as Arsham said, if you do see a patient who has an effusion, then it's important to drain them. And I typically do 2 sclerotomies, typically about 4 millimeters back in these small eyes. And we typically see serous fluid emerge from that scleral cut down. And we typically leave a window present to ensure we have continual drainage. Prophylactic sclerotomies is something that also I think could be worth considering as well. And it's something that that Arsham alluded to as well with his reference. Of course, lensectomy is amazing in these cases. We need to put our thinking caps on. As a shout out to our fellows and our visitors as well. But again, like I said, there's a lot of issues with these patients with regards to the risks around doing lens surgery in these small eyes, whether they're acute pressures or not. There's a whole litany of issues that exist that are present. One study that, again, Arsham perhaps alluded to is a study out of Moorfields, which basically looked at 100+ eyes that were less than 21 millimeters. And as you see, once the axial length gets shorter and shorter, the risk of complications increases significantly. Once you get less than 19 millimeters in axial length, the risk is increased by 20-fold. Of course, space creation is critical in these eyes. We have to deal with that. And we also need to maintain space, as we've heard from Havo. Mannitol is a routine for us. We typically give about 1 gram per kilogram over 30 minutes just before surgery. Using Helon 5 is important. And we'll talk a bit about doing a pars plana vitreous tap. Of course, dispersive viscoelastic helps the cornea. Sorry for trade names, but there's really very little like this out there. And something like a Helon 5 is incredible at really creating space that you need to work. As Havo mentioned, I think maintaining the chamber is really important to prevent further exacerbation of choroidal expansion and positive pressure. So be sure to do that at all times. Some people use an AC maintainer. What about a pars plana tap? Of course, it's very tempting. Get more space, work farther away from the cornea. And with trocars, we have great advantages for us using it from the anterior segment point of view. We do it all the time for many cases. But as Arsham mentioned, in these small eyes, we don't know where the retina insertion is, where the ora serrata is. And although normally we can get away with going back 4 millimeters, we know the ora typically is about 6 in average eyes. In these cases, they may be up to, retina may insert up to 2.5 millimeters. So just think about that. Where are you going to enter the pars, and where is the pars? A UBM is helpful. If we have to enter it, we typically go very anterior And we need to be mindful that, of course, we may end up hitting the lens. Malignant glaucoma, I'm not going to go into detail here, but is typically a constellation of findings precipitated by choroidal expansion, pushing the vitreous and losing conductivity of aqueous within vitreous. And when you have a small eye, a middle segment where the lens iris space is limited, the chamber shallows. And the definitive treatment for these cases, whether it means treating it or preventing it from occurring, is to create a unicameral eye. In my opinion, it is not to do a full vitrectomy. That may not be enough. In fact, one has to create a unicameral eye, and this doesn't require a full vitrectomy. It does require us to break the anterior hyaloid, though, and to make sure we have a good communication between the posterior segment and the anterior chamber. As we said earlier, again, be sure to maintain the chamber, very important, before pulling out with our hand pieces, because this is where the choroid may expand further and may become very difficult to maintain. This was the other study that was published from Arvind that Arsham alluded to. And this study basically showed with these smaller eyes that a single infratemporal sclerostomy was helpful in preventing postoperative uveal effusions. So even if there's no effusion in these smaller eyes, that is helpful to do. What about IOL calculations? Maybe I'll just quickly get a poll from the audience here, and I think I'll go to Havo for his opinion about what are we going to do for the lens here. We have a few options here, of course. You can imagine that these are unusual eyes, but what is your preferred way to calculate these lenses, and what lens do you use? And again, the audience can go ahead and vote on the polling. Go ahead, Havo.
Okay, great. Yeah, so this is a really tough choice. The IOL calculation is not going to be easy, and most people do not have the right IOL available anyway. So I think the most important take-home point here for most people is do not try to piggyback IOLs, because there's no space in there, and you're going to cause more problems than not. And if you do have the technology available, there are custom or special order, I should say, lenses like the Zytus Stream D, which might achieve the power that you need. And their IOL calculation formulas are proprietary, so you just have to kind of go with whatever the company chooses for you. Otherwise, just go for the highest available power.
Okay, Arsham, any comments on that? We have a couple people voting for piggybacks here.
Yeah, I'm not like Hava. I'm not a big fan of piggybacks. I mean, there are rare cases you can get away with that, but I would not go with that as your main kind of plan. One thing about the super cohesive thing, I kind of want to warn people about. A lot of that also depends on how much you're gaping the wound, because if you're working during the cataract surgery, like the rexus is a common spot where you'll see this, and you really gape the wound, the super cohesive viscoelastic agents can sometimes come out in mass, and then sometimes create a worse off issue. So just make sure that you're fulcruming well in there if you're using something that's very cohesive.
Yeah, I think that probably applies for most, but I will say with Helon 5, I mean, that stuff is really probably the thickest stuff you can use, and particularly to create space. I'm just going to show this graph here, because we assume, of course, with these small eyes, they have shallow chambers, and they may end up requiring an IOL that is very high power. But on the other hand, we actually see some work, not a lot of eyes in this group, but that these chambers may not be very shallow in the first place. In fact, if you look at this particular patient, if you remember actually that this patient's left eye, remember the right eye is a bit artificial because it's the patient's in malignant glaucoma, but look at the patient's left eye. I mean, that chamber is not particularly shallow. And in fact, our IOL calculations, because the 60mm eye may predict a very high power IOL, and you may get a myopic surprise. So these are always difficult. And that's why when we're picking lenses in these cases, it's very helpful to use a lens or an IOL formula that looks at multiple variables, like, for example, anterior chamber depth, looking at white to white, looking at lens thickness. And I think that's where the Barrett, I think the Olsen shines here, an optimized Haggis, Hill RBF, but there's not enough data to really support this yet, are all potential good options as well. Again, piggyback lenses, I think we heard already, this is a bad choice. I personally will put it out there. I don't like to be specific or definitive, but I think it's a bad idea. There's not enough space in these cases, and we do see angle closure and shallowing of chambers in these cases. I just don't think there's enough space for this, and I would really, really strongly avoid it as well in these cases. This is the best choice you have. Go for the highest power lens. That's okay. Leave them hyperopic post-op if you have to, but you can order a special lens. Now, Zeiss Extreme D used to be available, no longer available as far as I know. But the Human Optics Aspira lens can go up to 60 diopters. You can order it from Human Optics around the world, except maybe the US, sorry. But this particular lens, you can order it in the US to compassionate grounds. It takes a while. But this goes up to a very high power, 60 diopters in different steps. And I have found this lens easy to use. It is hydrophilic, and it can be placed through a sub 3 millimeter incision, which is very nice, not having to enlarge the incision. It is helpful too as well. We talked about goniosynechialysis. These patients often have synechia, and it's helpful to release the synechia if needed using some sort of intraoperative gonio mirror or gonio lens, and whatever technique we use. In this case, for example, using a pair of forceps. So we have this case here we spoke earlier. This is the patient that's presenting here. I'll just go through the video, and I just want to say again, for those of you that are going to attend the webinars in the future, we are posting the videos on our website, on the prismiinstitute.com/webinars website. So you can go ahead and watch the videos or watch them after as well, because often playing videos on webinars, the video is quite jittery. This patient has a 60 millimeter eye. I am definitely going to create a posterior sclerostomy because I need to make sure that we prevent postoperative effusions. Even though this patient did not have a frank effusion, I'm going to create an opening here because I know this patient's at risk. If there's an effusion, I typically do 2 quadrants, cut downs. If there's no effusion, I think 1 quadrant is usually enough. And again, I'm going here in this case, an infratemporal space here. And you can see how thick the sclera is. It's very thick. And once we get down all the way down, you can see the choroid, make a punch and leave that window open. You can do that after the phaco if you wanted to. I did it before. And I know I can keep it there now, and it'll be present postoperatively in the early postoperative period to address that. So that's the first point, is to I think, ideally do a sclerotomy, and that's the way I do it. Now, I decided not to do a pars plana incision for reasons I mentioned earlier, but this patient had mannitol. I also put this patient as a general anesthesia in this particular case. I didn't want to have any risk of any kind of squeezing or shallowing in this case, in a young patient as well. And the mannitol has helped us to at least soften the eye a little bit. And with viscoelastic, we can see the synechia still present. Our main incision can be a culprit, of course, for shallowing of the chamber, so make sure it's long enough and reasonable enough in size. A clear corner incision, I think, is fine. And here's a super viscous agent. We really get that chamber deepened up, the pupil dilated a bit, and we can then work under that super viscous agent. Capsulorhexis is performed fairly well. Be careful with hydro. This is where people get in trouble, because excessive hydro can cause burping of the viscoelastic and can cause the chamber to shallow. So be very gentle. This is essentially a clear lensectomy, and I find hydrodelineation is a really good pearl to facilitate the lens removal. And I typically use a horizontal chopping technique. But remember, before coming out, we always fill the eye with viscoelastic so the chamber does not shallow. And I've caught times, even for a subtle bit of shallowing, it can change the picture completely into a very difficult situation that you're dealing with. Cortical removal is fine. We put the IOL in. And as soon as I can, I'm going to suture that incision because I want to make sure that that eye does not shallow. That's important, again, to maintain the chamber. Thank you, Sophie. I got a little gift from my daughter. Always helps during surgery. Now, this is the important part here where we're going to do our iridozonular hyalodectomy. I do this dry. OVD is in the eye. My first thing is to do an iridectomy using the vitreous cutter on 1 cup per minute with high vacuum cut. And I do like to make the iridectomy large. You're probably going to be, wow, that looks pretty big. It'll get smaller as the eye heals a bit. But that's is where, if the iridectomy closes, then that channel basically becomes ineffective. Now we go to the cut mode, and literally I'm going to cut here into the zonulus and peripheral capsular bag. Make sure the haptic is not placed at 6 and 12. I'm sitting temporally because we want to avoid the haptic, and I'm going superiorly here. So the haptic's at 3 and 9. I aim posteriorly, and you see the chamber immediately deepens as I break the hyaloid. As soon as you can, inject some viscoelastic to keep the chamber formed. And so we've now broken the attack. We've broken the hyaloid. We removed some vitreous. And look how deep this chamber is. I mean, it is now hyper deep, just so the small amount of vitrectomy, that was real time. Finally, we need to make sure we release the synechia because that may not be enough to lower the pressure. And I'm using, in this case, a single mirror or a double mirror. It does not require tilting of the microscope. I'm going to put on the eye, microscope in your regular position, and look in and release the synechia dynamically. We talked earlier about the cosmetic iris, but I find in these cases, sometimes releasing the synechia isn't enough. The TM may be dysfunctional. And so in these cases, I often combine them with stenting procedures, like the eye stent. I do not like cutting procedures like GAT or trabeculotomies. They bleed too much in these cases. But an eye stent carefully placed is very unlikely to bleed. And with pressurization and leaving some viscoelastic in the eye, we can avoid this problem. But this at least lets us bypass the potential trabecular meshwork, which despite opening by synechialysis, may still be non-functional or less functional. So a couple in there helps. And at the very end, we'll close the conj and I'll move the viscoelastic manually. We don't want to go in there, remove the OVD in the chamber shallows, and then we've lost the benefit of keeping that eye formed. And these patients are going to end up being on Diamox, and we check the pressure the same day, make sure they're good. This is actually post-op day 1, and you can see the chamber is very deep. Eye was in position, and this patient actually ended up doing fairly well. So that's basically just some pearls. Beware of these small eyes, particularly for effusions of malignant glaucoma. Absolutely avoid filtering surgery. Most eyes don't need it, and they're fraught with risk. And my sort of cutoffs are, if anybody's less than 20 millimeters or a history of malignant glaucoma in their fellow eye, I perform a prophylactic iridozonular hyalodectomy, typically an anterior approach as I showed. I use 18 millimeters for me for a cutoff for doing a posterior sclerostomy, or if they have a UV effusion in their fellow eye. And that's typically what I do in my cutoffs and my own personal experience over many years with many small eyes. So finally, small can be beautiful. Thank you. So I wanted to just leave off maybe just a couple of minutes just for comments, and then we want to probably move on to our next case. Havo and Arsham, you guys hit it right out of the park. And Jeb, was there any other questions to ask that came up on the chat group here?
The majority we've actually answered. A lot of them were in terms of what lens you would use, and also in terms of you know, kind of the cutoff values that you were looking at in terms of when you would do what you were doing here. I think there might have been.
And that particular patient did end up being hyperopic post-operatively, around +4, +5 or so. Of course, totally happy, totally fine, and he wears RGP lenses anyway, so that person was fine. In that particular case, I did not have the time to order a special order lens, so I ended up using the highest power lens available, which was the SA60-40 diopter. Timing was of essence here, and I didn't have time to wait 6-8 weeks for a special lens to come in.
Can I make a usually the, oh yeah, sure.
Sorry, here. Just as if you're doing surgery with like a retina surgeon, say you need to deepen the AC and you're not going to do the PPV yourself, just really careful. If they do a full vit, it's much harder for you to phaco, especially with really steep Ks. The eye is hyper deep. So if you combine them, have them do maybe like a 10-second vitrectomy, and then you can go in and do the cataract portion, then they can remove the rest of the vitreous if that's what they choose. You'll still need to do the IZHV though. You still need to make the unicameral eye.
Good Pearl. Okay,
yeah,
I think.
Okay.
Go ahead, Havo, go ahead.
That's a great Pearl, Arsham. Yeah, one more thing regarding the IOL cuts. In an eye like the one that we saw, the right eye, given the malignant glaucoma situation, you might actually want to use a formula that does not take the ACD into consideration because everything's being pushed forward. For the other eye, the contralateral eye, your Barrett would probably be a good option, or one of the newer generation formulas. And that's also one of the reasons why you might have ended up with a hyperopic surprise, because the ELP, effective lens position, was thrown off by the fact that everything was being pushed forward during the MG, right?
Well, don't forget it. We had a 40 diopter lens, and he needed a 55 diopter.
Awesome.
So
yeah,
but a very good point. If you have an artificially shallow chamber, don't put that AC depth into the calculation for formulas that require it, or use it, I should say, like the Barrett. Leave it empty, or use the fellow eye. Good point. Okay, we're going to move forward, and I'm going to hand it off to Natalia.
Hello.
Thank you, Natalia. If you want to go ahead and share your screen.
Yeah.
And thank you for joining us from the UK, originally from Brazil. We can't get rid of the Latin flavor with Gisela and Natalia here today. But we'd like to have you guys here.
Okay. So first of all, thank you for having me here. I think that in difficult times, more than ever, Ike has this ability to have great ideas to bring people together. So I'm happy to be here. Thank you. And today we just brought a case that we had in our hospital that made us think about how much glaucoma surgery is evolving every time, and how much we have every time new options, and we have to keep questioning ourselves if we are making the best choices for our patients. So I think that's pretty much the discussion we want to raise here. Okay, so this patient, he originally came to our hospital to see the corneal team. So he had this complaint of a strange intermittent pain in his right eye that started 2 weeks after his cataract surgery and used to improve with steroids. When he was seen by our corneal doctors, they found out he had this opacity in just this infratemporal area of his cornea, and they made a diagnosis of endotheliitis in the right eye. And when he came to us, that was already November of 2017. So he was 75 years at that time. He's a diabetic type 2 patient. And past ocular history, we knew that he already had bilateral primary open-angle glaucoma, more advanced in his right eye, for which he had bilateral TREBs in 2011. And he also had cataract surgery in that right eye that complicated and needed posterior IOL exchange. We also knew he had bilateral Fuchs endothelial dystrophy, and his left cataract surgery was uncomplicated. He had a right DSEK due to the complications of his viral endotheliitis in the right eye. And in our examination, his vision was 20/60 in the right eye, 20/25 in the left. Pressures were 20 in both eyes. He was already on max topical therapy. So at that time, he was on monopost, Cozopt, and IOPG 3 times a day. And we could see he had a lot of synechiae in both eyes. And very importantly, when we saw this patient at the slit lamp, he had a lot of ocular surface disease. He was intolerant to many of the drops. He was presenting with a lot of side effects from the drops, and he was really keen to stop his medication. So that's the patient we had. Those are his visual fields. We can see his glaucoma is a lot more advanced in the right eye. And that's his specular microscopy. I know the photo is not really good, but it's reduced in both eyes, but especially in the right eye. And now I would like to raise the first poll, which surgery you would choose for this patient back in 2017, if you had these options of doing another trabeculectomy, going for tubes, or Sidepass, or Zen, or cyclophotocoagulation, or even GET. Having in mind that this patient this was his better seen eye, his pressures were increasing on maximal topical therapy, and this patient had a lot of side effects from all his drops.
So why don't we open up to our panelists? I think we have some panelists here to discuss this case, and I think the audience is voting. I'll be showing the results very soon. Who are our panelists, Jeb? We got Gok. Well, he knows already, but.
I won't jump in yet. I'll jump in when maybe another one of the glaucoma guys wants to say something. Or
sorry, could I add needling with MMC?
Yeah.
All right, so let's share the poll here. It looks like we have between the tube and the trap seem to be the most popular. There's some Zens, and then just a few smatterings for some of the other procedures that you listed there.
Where's the poll?
Did you want to go to the next one, Natalia, for 2020?
Oh, what do you think? Do you want to discuss the 2017 option? Do you want to go?
Let's do the 2021 as well and see how the two stand side by side. And
sure, let's go 2020. Okay. All right, Arsham, you're online too, I think. And Hava, what do you think? Any comments on this case? What you would do here? You got someone who looks like pretty advanced glaucoma with a cornea that's not the best shape.
So the advanced glaucoma is in the right eye, and we chose to do the
left eye
first.
Sorry, this is left eye first. Okay, sorry. So previous trab present in both eyes, pressures 20.
Yeah, I mean, I honestly, like, I try to give needling if they've had a trabeculectomy, and people will say, you know, the bleb's really flat, you can't get into it. You're really looking to break up the tract, so that's sclerostomy. And so whether the bleb's flat or not doesn't really preclude me from needling. If they've had a trabeculectomy before, I generally try to needle. Now, if they had really bad course of hypotony post-trab that was pretty recalcitrant, required more surgeries, I might be a little bit less inclined to do that.
Yeah, Asham, I think you make a good point there. Can you hear me?
Yeah.
Yeah, I think you make a good point about the needling, particularly if you got the trabeculectomy was in 2011, but even then, even if it's some years ago, you still got a chance of reviving that bleb. In this instance, you can see from the way that the question was answered that actually we went for an ab interno approach here. I think we wanted to try and avoid a bleb. This patient didn't have, the bleb was completely flat, a lot of ocular surface disease. He was keen to get off his drops and the disease was quite early. So without spoiling Natalia's next slide, we can probably go to that next slide there and then maybe have a discussion from what happened and why we went for that option.
Yeah, so when we saw this patient, our first choice was to go for a Sidepass and Goniosynechialysis in the left eye. And at that time, we also planned that following that, we would probably do a tube for the right eye, which is the one with more advanced glaucoma. The reason why we chose the Sidepass is because of his ocular surface disease. We thought that was the best option to get him off drops. He had previous trabeculectomies, so we didn't think that it would be likely for new filtering procedures to work. Tubes and Fuchs are probably not a good combination. And GET was questionable because, we could flare up some trabeculitis. We knew he had viral endotheliitis, and he also had a lot of synechiae. So that's what we were thinking at that time. And
I might just jump in here, Natalia. So
sure.
during these sorts of periods where the Sidepass was available, with corneal patients, often they present with very high pressures and present very acutely. Sometimes the disease is very early or they don't have a glaucomatous damage at all. If it's purely steroid responsive, but they're going to be on steroids for some months or even up to a year, sometimes the more conventional thinking is about doing a filtering surgery or a tube in these patients. But something to try and give you some months of respite during this period can be useful. And I thought the Sidepass was actually a good option in these patients, which was a very quick, safe surgery and effective in many to get the pressures right down off their drops. And should they need their contact lens use in the future, they still have that option there. So it's just an option. And whether any panelists have any comments about Sidepass use in corneal patients in their experience.
Well, I think that's why you probably presented this case, Gope, because we kind of assumed, of course, that with these procedures being fairly safe and in the angle, and therefore hopefully away from the cornea, we should have no problems. And I understand your rationale. This patient had synechiae, so probably wouldn't be the ideal patient necessarily for trabecular meshwork, and so hence you've chosen that. These are always difficult ones. Even in the Sidepass days, I've had sort of mixed results in these cases just because they've had previous surgery, they got synechiae, but I certainly understand the rationale. I mean, this patient has a pretty normal visual field, and so your desire was to try to avoid anything major. So I certainly understand the rationale for why you chose that. I'm a little curious about your choice of choosing which eye to do first as well, because if both eyes were 20 and the right eye got the advanced glaucoma, I kind of wonder whether that would have been the first one to perhaps address before anything else.
Yeah, good point. The plan was to do both eyes sequentially. Here, I think the better eye, the eye with the better visual potential and wanting to preserve that visual field as much as possible was the rationale for going in with the less advanced eye first, but to follow it up. But yeah, good point. And but the plan was always to get onto the second eye, the right eye, ASAP.
Okay, great.
So,
just to jump in for one quick second too, because it's being brought up on the forum talking about human herpes virus. And, I think we always assume viral endotheliitis or pressure spikes are HSV, but I really think CMV is really misdiagnosed a lot. And we know that the treatment is it's the steroids that does the work. It is the antivirals that, help prevent it from coming back. But most of these are inflammatory issues, not the actual infection. So if you put either CMV or HSV on steroids, they will get better. And if you don't know which one it is, you're kind of missing the boat, because you keep these people on Valtrex forever, and you're really not inhibiting the problem from coming back if it's CMV. And as Alan Carlson mentioned on the chat, if there was really just a spot, that EBV can present like that as well. So that's yet another, virus that you got to think about.
So Josh, just a great point. And just going back from in the history. So when the patient had their first, when the patient had the DSEK in the right eye, they had an AC sample taken, and they were negative for both herpes as well as CMV. But the patient was also on long-term acyclovir and was on a maintenance dose for many years. So the working diagnosis here was herpes-related, well, certainly a viral endotheliitis, but most likely herpetic-related. The presence of the endotheliitis was more disciform, which is a bit more in keeping with the herpetic rather than the cytomegalovirus. But Natalia will come on to it on her next point. This patient has been on long-term acyclovir, but was AC-TAP negative.
Great.
Okay, thank you. All right, Natalia, go ahead.
Okay, so our choice was to do the Sidepass. He had the Sidepass in April of 18, and he was doing really well. Pressures were 7 off medication right after surgery. The Sidepass was well placed away from the endothelium. We could see no retention ring. And a few months after, he came up with worse vision, and his pressures were on the teens, but already on all the medication again. And the left eye was presenting with the same endotheliitis and corneal edema as the right eye had before. So now we were questioning what to do for this left eye, because we had a very anxious patient. Yes, thank you. And he recently had got our letter explaining about the Sidepass withdrawal. So our patient was questioning us if we made the right choice and if the implant he had could have contributed for his endotheliitis. So we were thinking, should we leave the Sidepass or should we remove the Sidepass? Because at this point, he was already listed to have a left DSEK as well with the cornea doctors. So we were thinking if we should do something at the same time. So that's the poll.
Sorry, I was on mute. This is a really good discussion. The poll's going on. Please vote. The question is here now whether to leave the Sidepass or to do something about it. I guess you could obviously trim it as well, but it sounds like the Sidepass was sitting fairly deep into the angle, correct?
Mm-hmm. Yeah, it was well positioned.
Okay. And the inflammatory control was good.
At this point,
he did have
some. At this point, yes.
Yeah, he at that time when he presented with the endotheliitis, he did have some AC reaction as well, though. But he wasn't. Yeah.
Yeah, it does make you wonder whether the Sidepass can create multiple issues potentially. I mean, overall the results were fairly safe, but unfortunately we see corneal issues, yes, but we also sometimes see inflammation and uveitis in some of these cases as well. So you wonder whether that presence of the Sidepass in the angle, synechiae around it, in the uveal space, is exacerbating his inflammatory problem, and that would probably point me one way or the other. That being said, removing a Sidepass can be difficult. It can be pretty traumatic, lots of bleeding, iridodylisis may occur, and it's not easy. Sometimes you can pull them out, but in this case, that can be pretty positive with the synechiae present in the angle. It would be challenging. So it's a tough call there. I would rather leave it if I could, to be honest with you. Let me see what the group has shown here as far as your colleagues. It looks like it was pretty 50-50 here. So it didn't really give you much help to tell you which way to go on this one. And of course, if the Sidepass was longer in the AC, one can trim it, which is what we've done fairly reasonably with a nice Sidepass trimming device, if it was felt to be related to the cornea problems.
We decided to leave the Sidepass. We thought that the Sidepass was really well positioned, was away from the endothelium, and he had his left DSEK in early last year. The current scenario now, when we last saw him a few months ago, vision is doing fine. He's on probably too high pressures for the right eye. Right eye is 20, that's the more advanced glaucoma. Left eye is 16, but he is already on all the drops and he's now on Diamox 3 times a day. So we definitely have to do something for him. And last question would be, so this is what we have now.
I think before we go, Natalia, can I just jump in for a second?
Sure.
Yeah, I think before going on to the last question, maybe just get some corneal input here. I think the thing that made this case interesting for us was we've got a patient with Guttata, presumed Fuchs endothelial dystrophy, and they've also got they've got an endotheliitis as well. So they've got endothelial problems from different sources as opposed to just the one source, which is either an endotheliitis or a Fuchs dystrophy. So maybe if we can get some corneal input here about the potential dual pathology. Do you think it's a red herring, or do you think the dual pathology is making this case more complex than if it was just a single corneal pathology?
I'll jump in as a cornea person. So I think we do know that there's more likely glaucoma and Fuchs, but I think that people look at Goutte and say it's Fuchs, and that's the only thing that they think of. And I think we talked about this last time, but that's not true. You can have Goutte and Fuchs, of course, it's the most common cause, but HSV can have Goutte, any type of interstitial keratitis, macular dystrophy. So it's not pathognomonic of Fuchs. And in fact, you can have Fuchs without Goutte, so-called non-Goutte Fuchs. So I think that, if this person has had numerous flares of inflammation prior, they may not have Fuchs. Now the fact that they have Goutte means that they have had damage to, something caused their endothelial cells to proliferate DM. So clearly they are damaged, but it doesn't mean they have Fuchs necessarily. For what it's worth, I think we can say without certainty there's been damage to the endothelium. And I think a lot of people have talked about on the chat having them on a CAI, 2 CAIs here, if they're on Cosopt and Diamox, definitely doesn't help with the endothelium, but I think right now we have to worry about the pressure. And the last thing I just wanted to mention, because it has come up on the chat group, and just to make sure everyone sees this, if the TAP is negative, if your AC TAP is negative, but of course they're on antivirals or they're between episodes, you can do serology for antibodies. Now, as we know, most people with, your average 65-year-old will have a history of herpes antibodies because it's ubiquitous. But if someone doesn't have antibodies, it's more telling. So if they have it, it doesn't tell you anything. But if they don't have antibodies to say CMV or HSV, that can be important.
So I'm going to ask if one of our cornea fellows wants to jump in. Please feel free. There was a question though, Natalia, about antivirals. Is the patient still on oral antivirals? Natalia? I think you're on mute. Sorry, you're on mute.
Yeah, sorry. Yeah. The patient is on a daily basis of aciclovir since the beginning of the case.
I'm going to also, I brought Alan Carlson back again. Sorry, Alan, I'm picking on you a little bit, but I'm going to bring you in if you're able to talk. But also before that, Alan, before you speak, if Tanya or Giselle want to add anything more to what's been discussed, I don't want to put you in the spot. You're welcome to add, or I'll leave it to our junior colleague from Duke.
No, I love this discussion. I think that unless you have it really severe corneal decompensation, you can usually identify an inflammatory component separate from Fuchs endothelial corneal decompensation. And in doing so, we think of herpes. And while there are over 100 herpetic viruses, only 8 impact humans, and only 5 of those 8 impact the cornea. And the one that we talked about earlier, Josh mentioned, CMV, described by Richard Yee in Houston, and then also in 1986, the fabulous series that Alice Batoba co-authored with Kirk Wilhelmus and Dan Jones came out with their series of Epstein-Barr virus. And the thing that made me think of that was that what's unique about EBV is that you have anterior stromal involvement more centrally, but as you go toward the periphery of the cornea, you'll see these infiltrates migrate to the deep cornea, these pre-decimase nummular infiltrates that develop in the periphery. And the way this was presented made me think of that. again, you know, I'm a purist. I love to, you know, and here's the other thing too. I went for a long time without seeing EBV. I saw 3 cases in the last 2 months that I worked up as EBV, 2 of which are confirmed, 1 was negative. So I'm seeing an increase in all these herpetic viruses, but also, you know, including EBV. So think about Epstein-Barr virus when you've got these deep stromal infiltrates and these more mid-level anterior nummular infiltrates as you get more centrally. But again, it's going to respond to steroids. But, you know, knowing that you're dealing with an inflammatory process in this is going to help you as you also think about the surgical treatment.
Thank you, Alan. Thanks for joining us. Well, I'll let you continue, Natalia and Gok.
Okay. So that's the most recent test that we have from this year, February. And our last question will be, what we do for the right eye now? That's the one with advanced glaucoma and previous TRAB.
So let me launch the poll here. Now we're talking about the right eye here.
Yeah.
And by the way, there's been a couple of comments on the chat group, and please vote. I think Mitch Schultz talked about the difficulty in removing Sidepass, and I completely agree. I think it can be extremely difficult, and sometimes, believe it or not, you need to do a little cut down to get to it, and I don't recommend it unless you're absolutely certain you have to remove it. So I think that's so true in terms of doing that. And I will say that cutting the Sidepass, again, can also be challenging, although we've designed a cutter from MST, which I think is not bad single-handedly to cut it, and it can cut it pretty flush if need be. So that's something one can do if we're worried about the cornea. Okay, I think the poll has been launched. I don't know if can you guys see the poll? No?
No.
Let me do it again here. So the questions are, Natalia's asking us, pressure is 20 in the right eye, previous TRAB, and question is what to do in that right eye. You guys, you see it now there? Is it up there now?
Thank you. Yeah.
Okay, great. And you can see the visual field defect there. So this right eye, what was the reason for the previous IOL exchange, by the way? Some folks were asking that.
So his cataract surgery was not done with us, the right eye. That was in 2013. And we don't have records of previous surgeries because he was in another hospital.
Got it.
I don't know if Gok remembers anything from previous history.
No, I looked through all the old notes, and it's not in the notes there. But we assume it's probably going to be from complicated cataract surgery with a misplaced lens needing an exchange, but we don't know the details, and we don't know what the lens is.
Yeah, for some reason my polls are not showing up here. Let me just do it again. I'm going to relaunch this poll again.
Okay.
Hopefully that'll show now. There we go. Here we go. So a lot of choices here. There's different tubes that we've listed here that you can choose from. A second TRAB. I guess if you're going to do needling, maybe answer second TRAB. Either one. Pressure flows out there. GAT, Zen. All kinds of options here. And then we'll let our panelists get into this. Let me share this here. It's our last poll here. So Arsham, Matt, Havo, any comments? Jeb?
You know, if you're basing off of data, even post-failed TRAB, I know we have endothelial issues. I'd still go tube shunt here. You really need a pressure as low as you could possibly get it on the right eye with that mean deviation. And it's going to be a non-valve tube shunt for me. And I mean, we're not going to get into the techniques as far as how to like make them safer, but that's what I'd go.
Any particular tube shunt you would choose?
Yeah, go a non-valved, so probably not an Ahmed. But again, you have like the TVT trial showing you that post-failed surgery, especially post-failed TRAB, tube shunt's probably the way to go.
Yeah, I agree with that decision as well. You might want to consider using a sulcus tube as well if the cornea is not going to tolerate a tube in the AC well.
Good point. Good pearl. I guess, and again, I'm gonna mention what Ian's mentioned a couple of things here, just about looking for UG syndrome. Just based on that IOL exchange, could there be some element of UGH precipitating that, which I think is a good thing to add as well. So a lot of choices here. Looks like a majority picked an Ahmed glaucoma valve, but you see a smattering of choices here. So we're curious to see what you ended up doing.
We listed him for a PO tube, which is a non-valve tube, and that was supposed to be done now, but let's see.
So I think here
Hopefully
was
it won't take much longer for us to be able to go back and operate.
so I think here, having been stung a little bit by the Sidepass, trying to do a quicker, non-invasive ab interno surgery for the right eye, as Arsham said, that needs that lower pressure with that much more advanced disease. The tube shot was the way that we thought we should proceed. The rationale behind the Paul tube, I've done a few cases now, not that many, but it's a 100 micron tube versus a 300 micron tube. So in terms of potential endothelial damage, then it's potentially safer. Again, Hava's point about placing it in the sulcus is a good point as well. It's really trying to highlight how even in 3 years, the options that we have for glaucoma surgery, and in this particular instance, glaucoma surgery in the corneal patient, changes, and how actually, as Ike had said, in a patient with an inflammatory component, even an ab interno procedure in the uveal or suprachoroidal space can potentially spark up an inflammatory process as well. So lots of things to think about when you're making your surgical decision, not just about the IOP, but also about other complications and implications from the choice of your surgery.
Well, great. Thanks so much for sharing that case, Natalia. I always love these combined cornea, glaucoma, uveitis questions that come up. They're always challenging. So thanks for sharing that.
Thank you.
And where's that picture of?
That's Seven Sisters. That's here in the UK.
In Brazil? Where in Brazil is that picture?
I love the fact that you say you got a picture of yourself out and about and then say stay home.
That was before the lockdown.
So listen, I want to thank everybody. While we have people here, we had about 650 folks online, which has been fantastic. I just want to get some input from some of you here in terms of what kind of formats do you like. I hope this poll is showing. It's basically what kind of webinars that you like the most. Cases with discussion, didactic lectures, video, journal clubs. Just give us some input as far as what you like. This has been great having such an international crew. I'd love to be able to pick up folks from the audience like Alan Carlson. Thank you so much for being here as well. And Matt Schlenker as well for joining in, along with our panelists that have been fantastic. And our speakers, of course, our presenters presenting such really interesting cases. So thank you. Just by this poll, it looks like you guys are liking cases with discussion, some videos. And so we will try to get some papers as well, but I do hear you. Our next session actually will be on Saturday at 12. So if you do visit the website, and Jeb, maybe you want to put that website up there so people already know it already, I guess, but that's something you can get updates for. One last poll in terms of what topics you're interested in cataract or complex cataract, glaucoma, cornea, retina, uveitis, neuro, peds, oculoplastics. There's no it's not in any particular order, of course. So please give us some thoughts as well. It's really been great to have everybody here. You do feel closer to each other, although you're physically apart. Although we all live in different parts of the world, we all are facing the same threat. And so we do need to stick together and we need to learn from this, and we need to kind of find ways to come out of this stronger. And so I do wish, again, everybody great health and may this pandemic pass through without impacting us much more, I hope. Please email us some questions you may have. Let me just show you what the results were here. We have a number who are complex cataract and cataract, and yeah, look at glaucoma, man, right on. With cornea, retina, uveitis, and other procedures as well. So that's great. We're going to continue doing this. Next Saturday, like I said, we have more of an OCT, case-based OCT format where we're going to be showing cases by two specialists, one in glaucoma, one in retina, going through cases with pearls with the latest in OCT management with Panelist. We'll be able to do polling as well. And then next Tuesday, like I said, at a special time, we have a combined joint Prism and Ophthalmo University, for particularly geared toward those that are earlier in their careers or training, about going from good to great, and talking about the mindset, talking about the approach, and then specific surgical and microsurgical learning tools and suggestions. And then we're back on Wednesday again at 3 o'clock. I think I'm going to give up my day job as being a surgeon. I think I'll just stick to this, just being a host in these rounds. It's always about reaching people. I mean, whether we go to meetings or whether we do surgery or whatever we do, so much of what we do is because we reach people, our patients, our colleagues, our friends, and this is just one of those means to do that. And I know all of you, you guys are our family. We're all family in this. We're all ophthalmologists. We wear that with pride. And this is, again, a chance for us to share. So please keep the feedback coming. Stay safe, whatever you do. I pray for all of you that you stay safe and your family stay well. Let's find more means to collaborate and do things. And I look forward to seeing every one of you at meetings where I can at least give you a hug, maybe from afar. Hopefully not so much in the future. We can do that in person. And again, Godspeed to those that are recovering. We're remembering those ophthalmologists and anybody, of course, who's been affected by this. There are some in the ICU, some have been intubated, and some who unfortunately died as well. So they're in our thoughts. So thank you again. It's been great being here. I look forward to these sessions, and may you again have a great week. We'll see you guys on Saturday. Please stay in touch. And thank you again for all those who contributed. Have a great day. Thank you, guys.
Thank you.